Hello and welcome to our activity number 8, lecture on clinical trial design. And this is for ONPS 2304, clinical trial design and management. Let's look at our learning objectives for the lecture now. We want you to be able to discuss the merits of a crossover clinical trial design. We want you to be able to understand and illustrate what a randomized double-blind placebo-controlled trial is. And we want you to explain what a factorial design is in clinical trials. And finally, we want you to be able to judge the merits of different endpoints in clinical trials. Okay, so section 1 is about crossover studies, and this supports learning objective number 1. Okay, what is a crossover study? So we've talked about crossover studies very briefly. So a normal trial design might be a comparator, where you compare drug A in one group versus drug B in another group. However, you can also compare drug A and drug B by crossing over halfway through the trial. So as you move down through the first 6 weeks, for example, this arm gets drug A, this arm gets drug B. 6 weeks later, they wash out, and then we swap. So that each participant gets both drug A and drug B, albeit for a shorter time than you might have had in a straight comparator trial with a parallel design. So a crossover study compares the results of the two treatments in the same group of participants. All the participants get drug A, and then they get drug B, or they get drug B, or then they get drug A. So all participants get drug A, all participants get drug B. Between the two periods, as I mentioned, there's a washout period. This varies depending on what drug you're putting in the patient. Some take longer to wash out. The main advantages of these trials are that it's the same group of people that you're comparing drug A and drug B versus. You don't have to worry about having two different groups of people who you've tried to match, but you may have missed something. So the within participant differences are much smaller because of the same people. I'll grant you they're the same people at slightly different times, and there's a different ordering of the drugs, but these are much smaller differences than when you've got two completely different people, one taking drug A, one taking drug B. So other trials have between participant differences they have to worry about, which they try to reduce by having a selection criteria for matching to make sure the cohort is very homogeneous, but it's still better in the same person. Another advantage of the crossover trial is it can take a lot fewer participants to get the same kind of data, although it's a trade-off of going longer. So if you have a comparative trial that runs 6 weeks, you can go A, B at the same time, be done with 100 people in each group. That's 200 people. With a crossover trial, you do A, B with 50 people in each arm, and then BA with those 50 people again in the other arm. So it takes twice as long, and you get the data eventually for 100 people with both drug A and drug B. So this is the simplest design. The cohort is here. You randomize them into two groups. The first group gets drug A first, washout period, drug B. The second arm gets drug B first, a washout, and then drug A. So in the end, everyone has A and everyone has B, albeit with a difference between the order. The washout period should take away any ordering effects, but this is something that would need to be analyzed within the trial to make sure that this washout effect was actually successful. Okay, now, it's not all wonderful things about crossover trials. There certainly are disadvantages. The main disadvantage is that you have to be able to wash the drug out. If you've got a drug that takes months to wash out, this could be a real problem for the clinical trial. It might be easier just to run two different streams of people that don't wash out. This is a bigger problem. If you're washing the drug out and you're treating for a longer time, more than twice as long as the normal trial, so the comparator might run 6 weeks, and then there's a 2-week washout, and then another 6 weeks. So that's actually 14 weeks versus 6 weeks just for a straight parallel comparator trial. So the problem is that the condition or the disease that you're looking at has to be stable for that duration of the trial. And many diseases aren't stable. Some of them are cyclic. Some of them go into flare and remission almost at random. So this is a problem. So for instance, major depression is known to be cyclical, and this is a real problem. But also antidepressants are known to be slow to wash out and slow to develop an effect. So between these two factors, a crossover trial would be inappropriate for a major depression study using antidepressants. Okay, Let's talk about a particular example here. Let's talk about a crossover trial where we're doing patient preference in a migraine therapy. Patient preference is important. This contributes to their overall feeling of well-being and quality of life, even if the drugs appear to be doing exactly the same thing. There's always slight differences in the way drugs are metabolized, side effects, adverse events that they may have heard about associated with the drug. So a patient preference study is a good way to find a drug which works for them. So drugs are used to treat migraine attacks. The class of drugs is triptans, and they're designed for quick action and not to hang around. So they're ideal for this sort of crossover trial because the washout period is, hours. The migraines are not stable. They can come on at any time, but within participants, individual attacks that they have are relatively similar. So the first attack versus the second attack should be about the same. So if they take one drug for the first attack, the other drug for the second attack, they should be able to give a reasonable qualitative review of that effectiveness of the drug. So the triptans, as I said, are suitable for a crossover trial. Here's a crossover trial from 2007 where they did that. The results were that there was no major difference between the two major triptans, the elmotriptan and rizatriptan. So let's have a look at that. So here's the design of that trial. So here's our cohort, 183 triptan-naive subjects. So this is important because this is a preference. So if they've been taking a triptan that they already like, then it's not really a fair comparison between the different triptans. So these people haven't ever had triptans before. They've been recently diagnosed as needing triptans, and they have mild or moderate migraine attacks. So they're randomized so that half of them get the rizatriptan as their first drug for their first attack, and so they're no longer naive on the second attack, but they haven't developed a strong preference at this point, presumably. The other half get the elmotriptan as their first drug, and then obviously the washout's almost immediate. And then on their second attack, whenever that happens to occur, they take the rizatriptan. And as I said, the result was that both drugs were equally well liked by the participants in this trial. So some common uses of the crossover study are to compare doses of the same drug. For instance, this trial here in 2007 was a randomized double-blind crossover trial of once daily controlled release tramadol versus the immediate release form, and we'll look at that in a second. Also, we have comparison of branded versus generic preparations of the same drug. For instance, this paper here in 2007 as well, which we'll look at as well. So here's our active comparative design for different formulations. So here we've got the immediate release versus the controlled release. Tramadol. Tramadol is for pain. It's a opioid pain medication. So we have our cohort on the top here, 122 subjects with moderate or severe pain, randomized into two arms for either the controlled release first or the immediate release first, washout, and then swapping over to the other drug. These people have ongoing pain, and so it's a suitable sort of disease because it's very stable over time. And so what we found was that there was a significant improvement in pain relief control in the controlled release versus the immediate release, and this would make sense. So the immediate release is going to have a sharp spike in concentrations and get rid of pain immediately, but for a long-lasting condition like this, a controlled release formulation or extended release formulation will allow pain relief to happen over a longer period of time, so the quality of life will be better. And here's our other trial looking at the generic versus the branded formulations. So our cohort here is 62 subjects with benign prostatic hyperplasia. So this is a prostate tumor essentially. Randomize them into two arms. Take the generic terazosin or the branded terazosin. Wash out, come back. One of the reasons that this is a good disease is because, again, it's very slowly growing, very stable disease, and can be assessed very easily. So in this case, both the branded and the generic were equally effective, and this is obviously what you want to see, that the generic version has been manufactured to the same high quality and has the same release characteristics and the same amount of active ingredient in it. Okay, let's talk about some more advantages of crossover studies. So, as we said, one of the advantages is that require fewer participants, albeit for a longer time. One of the